Hello and welcome to Connected with Latham, where we discuss ideas, legal developments, and business trends shaping the global economy. This is the 19th episode of the Latham & Watkins Drug Pricing Series, and I'm Chris Schott, a partner in the healthcare and life sciences practice in our Washington, D.C. office. I focus my practice on all things market access, and that includes manufacturer compliance related to the Medicaid drug rebate program, Medicare Parts B and D, and the 340B drug pricing program, as well as, of course, implementation of the Inflation Reduction Act and other healthcare reform initiatives, such as state laws. Joining me is Danny Machado, an associate in our Washington, D.C. office.
Hey, Chris. Great to be here. And for our listeners, just a quick plug for the Latham & Watkins Drug Pricing Digest. It is back, and if you want it in your inbox at the start of every other week, just click on the subscription link in the podcast notes.
Thanks, Danny. Today, we're happy to welcome Allan Thoen as a guest on our podcast. Allan is Director and Associate General Counsel at Sandoz. Allan, do you want to introduce yourself?
Yeah, first of all, thanks, Chris and Danny, for having me on. Yes, I am in the legal department at Sandoz, which is one of the largest pure-play off-patent drug manufacturers in the world. Here today, though, I am here only on behalf of myself, and I am not speaking for Sandoz, so this is just my 2 cents. Informed, though, by many years in and around this space. So happy to be here.
Thanks, and thank you for joining the podcast today. In each episode, we focus on a specific topic that is relevant to market access, drug pricing, or the pharmaceutical and healthcare sectors more broadly. And after discussing the substance, we ask the question, which Olympic sport is it like? And we have the list of Olympic sports here to see which most resembles the topic in terms of strategy, complexity, or frankly, level of conflict. So Danny, kick us off. What is our topic for today?
Well, as our listeners probably know, there are various drug pricing conferences throughout the year. And there are 2 that particularly stand out. One is in the fall in Chicago, and then there's a similar conference in the spring, the Pricing and Contracting USA, which just concluded in Philadelphia. And these conferences bring together many of the drug pricing stakeholders, such as drug manufacturers, consultants, outside counsel, as well as government in many cases.
Right, Allan, and you and I, we both attended this conference. What did you think was the most prominent issue here in Philadelphia?
Well, so the agenda, of course, was put together quite some time before the conference, and so it covered a wide range of issues that don't necessarily map onto the most current events, but the issue that certainly people wanted to talk about, and that was in the front of a lot of conversations, was the recent executive order from the White House on most favored nation pricing for drugs, so international reference pricing, as it's sometimes called also. And then, of course, PBMs and 340B. 340B is a big one also, but I would say MFN pricing was the hot topic.
Yeah, I had the same impression also, and things are potentially moving fast in this area. So listeners should bear in mind that we are speaking here today as of the date of recording, which is June the 9th. And speaking of things moving fast, as I was going up to the podium to give my presentation as part of the panel, HHS posted things on their website right at that moment. But maybe to set the stage, I'll start by giving a bit of a background on how we got to the MFN discussion that we had in Philadelphia and what's been happening. So just a very high-level brief history. During Trump's first term, near the end of the term, he tried to implement most favored nation pricing in Medicare Part B as in boy. And maybe just to step back, what's most favored nation pricing? Well, Allan, like I said, it's a flavor of international reference pricing where you look at a basket of ex-U.S. countries and you look at the prices in those ex-U.S. countries and then you sort of apply those prices in the U.S. And most favored nation is among the harshest alternatives because you look at the lowest price in these various countries and then apply that somehow in the U.S. So like I said, in Trump 1, he tried to do this in Medicare Part B as in boy. So instead of reimbursing on ASP plus 6, it would have been most favored nation as the basis. That was stopped in court for procedural reasons, so not for the substance, but due to the procedure through which they tried to implement that. And then fast forward, I guess, to April 15th, when Trump issued the drug pricing executive order, and there was a paragraph in there that talks about how Medicare needs to get the true value of products. It's pretty cryptic, and a lot of commentators looked at that and thought, well, this might be a veiled reference, again, to international reference pricing or most favored nation. The next development was the most favored nation executive order on May the 12th. And here Trump essentially said, we, the government, will communicate most favored nation-based pricing targets to U.S. manufacturers. And if there isn't significant progress in lowering U.S. prices in connection with those targets, then there's a list of other horribles that would happen. And the first on the list is regulatory plans to somehow impose most favored nation in regulation in binding fashion. It's unclear what those things would all look like. The MFN was devoid of any meaningful detail about how this MFN pricing would work. Next up was this posting on the Health and Human Services website, which, like I said, went live just when I was walking up to the stage in Philadelphia. And in this posting, there's basically just one paragraph. And in this one paragraph, HHS says, well, what are the relevant countries? It's OECD member countries, so the Organization of Economic Cooperation and Development. So it's those member countries with a GDP of at least 60% per capita of that in the US. And then it relates to drugs without generic or biosimilar competition. So brand drugs with no generic or biosimilar competition. And that's pretty much all that's in there. And again, it's missing many important details. I'll just mention one. Where in the US is this price supposed to apply? None of that is spelled out. There was one more odd development on the Customs and Border Protection website, one that we don't necessarily track all the time in drug pricing land. They made a posting referring back to MFN and saying, well, HHS has posted MFN targets, and by the way, when manufacturers report import and export pricing to Customs and Border Protection, make sure that's correct. Make sure that information is correct because you need to report correct information. So that's kind of the state of play, I think, as of today anyway. I would say at the conference, there was a bit of a split among the drug pricing outside counsel bar. Half of folks, I think, were believing that there would be further government publications as it relates to the most favored nation price target. And so I would say half of the drug pricing bar was of the view that there would be more forthcoming there in terms of either public statements with actual price targets and actual drugs listed, or maybe private communications from the government to select manufacturers on specific drugs. I'd say roughly half of folks had the other view, which is basically, well, that's it. So we've gotten in this basically one relevant paragraph from HHS how we're supposed to figure out the price targets, and that's it. So now industry go forward, figure out your own targets, and then figure out how to comply with those targets that you yourself have pulled out of the hat. I'm not sure exactly where to land on this, just because in Trump land, nothing's real until something actually happens. So far, not that much has happened. We've had the EO. We've had sort of a sloppily drafted posting on the website. And it's odd to explain sometimes to folks that a policy that will impact billions of dollars and is shaping up to be a significant threat to this industry is being addressed in something on a website, right? You would think that more would be necessary, but maybe more is forthcoming. So we'll have to kind of see with that. But Allan, there was more in the Most Favored Nation executive order than just the threat of the Most Favored Nation policy itself. What other provisions in that EO were a focus in Philadelphia?
Well, when I read the executive order, one thing that sort of surprised me to see in there was in Section 4, it talks about directing the Secretary of Health and Human Services to facilitate direct-to-consumer purchasing for pharmaceutical manufacturers to sell directly to patients. So that's an interesting idea that I hadn't thought to pair it together with this MFN pricing idea, but the administration is doing that. It's unclear what that would look like in this context. In other areas, we have seen some manufacturers, dipping a toe in direct to consumer sales for specific products. I think we've seen some of that have high consumer demand, like with the newer GLP-1 drugs, for example. But is there potential for manufacturers to do more with DTC sales? There's a good amount of dissatisfaction on the manufacturer side with current supply chain, and the situation we have with really large gross to net spreads between a high list price and lower net prices, and the industry talks a lot about how the middlemen are the source of that and the reason for that. And so if you think about direct to consumer sales, that kind of cuts out the middlemen in the most extreme way you could. So when it comes back to directing the Secretary of HHS to remove barriers, then what might those barriers be that HHS might be able to remove? That's an interesting question to think about. A lot of the barriers are commercial just because manufacturers currently are not set up to do retail sales for various reasons that are not all the same for all manufacturers. But there's commercial barriers, and then there certainly are some regulatory barriers, although not as many as you might think. So it's interesting to think about what HHS might be able to do to promote DTC sales from manufacturers, and whether that could be something good or could be a bust, or how that might turn out.
Thanks, Alan. So it certainly seems like the executive order talking about MFN and both the MFN and the direct-to-consumer sales seems to really be sucking the air out of the room. But wondering if you two, and especially you, Alan, if you have any other themes that you saw come across at the conference.
Well, not surprisingly, I guess I would say that two of the other prominent themes were challenges and changes to the PBM model and the 340B program. Both of those got a lot of attention.
Oh, yeah, we certainly cannot have a drug pricing conversation without 340B coming up. That makes perfect sense to me. I wonder if before turning to that, Alan, you could talk a little bit about the discussions around PBMs that you raised.
Sure. So a lot of it had to do with bringing, what are the current developments in the various legal and regulatory challenges to the PBM business model. We certainly have seen a lot of antitrust focus on that, some at CMS as well. The FTC has put out, that at least a preliminary report last year that got a lot of attention. And so there was good amount of panel discussion about that and where that's going. And then there's a whole slew of lawsuits against PBMs, on similar themes. And so that was part of the discussion as well. But secondly, and kind of what I thought maybe was more interesting than that, was there was also discussion about more bottom-up changes that are happening in the market that might be kind of undermining the current PBM model, through the market. For example, we heard about health plans such as a group of blue plans, which together compose a pretty large segment of the market, who have banded together, and they're trying to build an alternative way of paying for drugs that gets away from the high list price, low net price model that's been dominant. And so they talked about that, and that was one example. So what we might be seeing here with this antitrust and other focus on the PBMs is that this might be another case where the wheels of justice grind slowly, so to speak. And by the time regulatory or legal challenges to that PBM business model start to bite, this might be another one where we see the market itself is already moving on. So that was an interesting sort of window into this issue at that conference that I thought was notable.
And let's not forget, certainly, that there are state legislative initiatives that may also impact PBMs, like Arkansas becoming the first state to prohibit certain pharmacies owned directly or indirectly by PBMs, and other states that we're keeping tabs on, which are also looking at their own legislation.
Yeah, that's right. And we're seeing quite a bit of activism, of course, from states as it relates to drug pricing, and much of it in 340B. So turning now to this vexatious program, Alan, what were some key 340B topics that were discussed in Philadelphia?
Thanks, Chris. Well, you can't be at a conference with a lot of pharmaceutical manufacturers and not have a lot of criticism of 340B. So there was a lot of that. But more specifically, there was a lot of discussion about some of the attempts that are being made in the market to try to move 340B pricing to a rebate model, which has been kind of an idea that has come to prominence recently as a way to make the program more transparent and make it easier to track duplicate discounting. So when a drug is dispensed to a 340B patient who also happens to be on Medicaid, for example, or who happens to be eligible for one of the new IRA discounts, to make sure that those can be deduped. And the rebate model has been put forward as one solution to that. So there was quite a bit of effort at the conference to explore that rebate model topic, although it's run into some challenges, of course, as we know, but that was a big part of that discussion about 340B.
Yeah, and I think, as you said, some challenges here. I think on the first day of the conference, the district court opinion came down on the litigation where manufacturers were defending their 340B rebate models, and the court basically ruled in favor of HRSA. I believe the manufacturers involved, or at least some of them, have already signaled they will appeal. During the litigation, HRSA had indicated that they would release guidance on this topic, and there is an entry for that on the OMB website. So it seems that there is indeed guidance forthcoming. What that might look like, we don't know. Maybe it'll just say rebate models not allowed unless you ask for permission. Who knows? But it's another thing to stay tuned on that to see what kind of regulation might be coming out of OMB on that topic.
And also, we should mention, right, the first ADR decision that came out under HRSA's revised framework, which was announced very recently, but only in the form of a very brief summary, which seemed to indicate that the covered entity made an allegation of overcharges related to a contract pharmacy issue. The ADR panel basically just concluding there is no overcharge violation, and very summarily just agreeing with district court and appeals court opinion on that front. So it certainly looks as though the ADR board is following federal court precedent there, though of course it remains to be seen if this will be the case in future ADR decisions. But once again, we just see that tug of war, that conflict between manufacturers who of course fund the 340B program and then the covered entities. And along those lines, we've seen that Apexus usually attends these conferences, and they did so this time around. But Allan, did you see covered entity voices at the conference as well?
Yeah, there was a whole panel discussion devoted to that, and that was a very interesting facet of it because it was really another face of 340B. When you listen to the covered entity side of it, there was a group of representatives from several different hospital systems, and some in rural areas and some in different parts of the country. And they gave concrete examples of how they and their patients, how they use the indirect subsidy that they get from the 340B program to help their systems and their patients. So that was interesting. On the manufacturer side, it's easy to only see the abuses and excesses of 340B and maybe how the indirect subsidy structure of it causes economic distortion in the healthcare system. But nonetheless, that panel was a good reminder that the 340B program also has a lot of support around the country, and the supporters can tell a pretty good story too about how the program helps a lot of people. So on the manufacturer side, if thinking about ways that it could be improved or changed, I think it's important to bear in mind that to be politically viable, solutions are going to have to take into account that base of support this program has, just as a matter of political math.
Thank you, Allan. Yeah, and that makes sense, particularly because there's basically a hospital in every congressional district. I would also say it's not my observation that pharma industry is generally completely opposed to this program. I would view it more as being opposed to the complete lack of oversight, the lack of transparency. And, yes, those cover entities that come on a panel at this conference to talk about how they use the program, those are going to be the ones that use the program as intended, where they use the 340B spread to plow it back into patient care and into their mission. It's probably the ones that we would not see at the conference, where the lack of oversight might allow for some other conduct there. Well, this has been very exciting to hear these different voices from this conference. So, Allan, thank you very much for sharing those takeaways.
Thanks again for having me here. I really enjoyed it. So thank you.
And I would say, if nothing else, it's clear that the industry should be aware that there's a lot of moving pieces involved here. So it definitely makes sense to devote resources to tracking all of this. And so before we go to the question we had posed at the very beginning, which Olympic sport is it like? Speaking of tracking developments, let me echo the plug Danny made at the beginning, and also give a quick shout out to our Latham Watkins Drug Pricing Digest, and we'll put the subscription link in the podcast notes. So, Allan, we'll start with you. What do you think? Which Olympic sport is all of this like?
I would pick the modern pentathlon. That requires competency and excellence in 5 different disciplines: swimming, fencing, riding, pistol shooting, and running. And I think this range of issues that we've just covered is dealing with this also requires a lot of versatility and bringing together different disciplines to really handle it fully. So that's what I'd pick.
I like that one, Allan. That one's great. Honestly, I went with a different sport, but honestly, probably in the same vein. I went with mountain biking because it involves cycling off-road and very mountainous and very hilly terrain, and hearing you, Allan, and Chris discuss the various developments that we that we're hearing about, such as most favored nation pricing for pharmaceuticals, litigation over the rebate model in 340B, state legislation, I think of it as a rugged terrain with a variety of just obstacles, rocky trails, jumps, drops. Drug manufacturers more than ever need to really keep a very careful eye on these and other developments, and these conferences are a very helpful means to stay abreast. Chris, I wonder what Olympic sport you picked.
Yeah, I'm going to say one of the most important Olympic contests is when the different cities apply to actually host the Olympic Games. And it was odd to me to see in the news the last couple of weeks that my hometown of Berlin is applying to host the Olympics in 2036. So that to me it's a little odd, but I'm gonna go with that. I think that nicely wraps up our podcast. I'm certainly ready for the after party. Danny, where are we going?
Well, I know that before we started recording, we were talking about how nice of a day it is outside, and Chris is an ice cream lover. Allan, I don't know if you know that, but Allan, I don't know about yourself, but would you want to go grab some ice cream at Dolcezza just up the street at City Center here in DC?
That sounds great. Yeah.
That sounds wonderful. I can't wait to go. And I will also tell you, I don't share desserts, so we're going to have to be getting 3 separate desserts, just to make that clear. Thanks to Allan for joining the podcast today and sharing insights on the Philadelphia conference. And thanks to Danny for being a moderator. And thank you to our listeners for checking out the Latham & Watkins Drug Pricing Series, which is part of our Connected with Latham podcast. You can subscribe and listen to new and archived episodes of Latham's podcasts on lw.com, Apple Podcasts, Spotify, or anywhere else you listen to podcasts. If you have questions or would like additional information, please email us using the links located in the show description. We hope you'll join us again next time.
This podcast is provided as a service of Latham & Watkins LLP. Listening to this podcast does not create an attorney-client relationship between you and Latham & Watkins LLP, and you should not send confidential information to Latham & Watkins LLP. While we make every effort to assure that the content of this podcast is accurate, comprehensive, and current, we do not warrant or guarantee any of those things. And you may not rely on this podcast as a substitute for legal research and/or consulting a qualified attorney. Listening to this podcast is not a substitute for engaging a lawyer to advise you on your individual needs. Should you require legal advice on the issues covered in this podcast, please consult a qualified attorney. Under New York's Code of Professional Responsibility, portions of this communication contain attorney advertising. Prior results do not guarantee a similar outcome. Results depend upon a variety of factors unique to each representation. Please direct all inquiries regarding the conduct of Latham & Watkins attorneys under the New York's disciplinary rules to Latham & Watkins LLP, 1271 Avenue of the Americas, New York, New York, 10020. Phone number 1-212-906-1200.